Hello, this is Dr. Hausinger, and we're going to be talking about special populations and alternatives. Okay. So, we've talked a lot about traditional treatment this semester, and your book is fairly liberal and progressive in terms of looking at, abstinence might not work for everybody, and it can be damaging to impose that. Looking at being more flexible and using the ASAM as the tool and what it was intended for instead of overdiagnosing and putting people into cookie cutter treatment plans. Okay. So this week you have a lot of different resources about different populations, and some of the populations that we have specialized knowledge for and that we need to look at a little bit more closely, and not as a group, but and what I mean by that is not having, okay, you have one group, a mixed group of people, okay, but when you're doing individual treatment plans, we need to look at the intersectionality of our clients. Okay, so men, women, adolescents, pregnant, postpartum mothers, veterans, LGBTQ individuals, Native Americans, Native Alaskans, persons experiencing homelessness, seniors, and those with co-occurring disorders all have different needs and different experiences, and therefore we need to tailor our treatment plan specifically for them. And what I mean by intersectionality, it's a feminist term, meaning that we need to look at where all of these different things intersect and in order to really look at our person. So for example, a homeless male veteran with HIV who has a co-occurring disorder is going to be different maybe than a non-veteran housed male. Okay. So going back to the stage of change, which you've had many times now, but it's so wonderful, and I hope that this haunts your nightmares. Remember that it is not linear, but it is a spiral here, okay? And we can come in and out of the stages at any point in time. And in our newer model of treatment, we don't want to say, oh, you're in denial, there's no help for you until you change your mind. We want to help that person move out of their ambivalence into a decision that they are comfortable with doing. Okay. So again, reviewing the ASAM, you have 6 different dimensions, and they represent a holistic view of the person's life. So acute intoxication or withdrawal potential, exploring an individual's past and current experiences of substance use and withdrawal. Dimension 2 are biomedical conditions and complications. This is the medical history. Exploring an individual's health history and current physical condition. Emotional, behavioral, or cognitive conditions and complications. Exploring an individual's thoughts, emotions, and mental health issues. Dimension 4 is our readiness to change. Exploring an individual's readiness and interest in changing. Whoops. Dimension 5, relapse, continued use, or continued problem potential, exploring an individual's unique relationship with relapse or continued use or problems. Dimension 6, recovery, living environment, exploring an individual's recovery or living situation and the surrounding people, places, and things. Okay. We talked before about our continuum of care in a traditional model, and you saw this recently with your assessments. So we have 5 broader levels of care: early intervention, outpatient, intensive outpatient / partial hospitalization, residential services, or medically managed intensive inpatient. Okay. The decimals here represent the benchmarks along a continuum, meaning patients can move up or down in terms of intensity without necessarily being placed in a new benchmark level of care. Okay. And the main difference between these dimensions here is the level of medical intensity. Right? So we're looking at hospital, 24-hour medical staff, doctors, nurses, etc. Clinically managed high intensity. There might be a doctor on staff. There might be a nurse there's every day, but it might not be 24/7 medical care like in a hospital setting where there's doctors and nurses there all the time. In our traditional continuum of care, we might have somebody go to medical detox and then go door to door to intensive inpatient, intensive outpatient, and then aftercare and maintenance. Okay. Types of treatment modalities that we have. Treatment approaches: cognitive behavioral therapy, group and individual, evidence-based psychotherapy, motivational interviewing, contingency management, and harm reduction, all of which we've talked about this semester. In traditional inpatient, outpatient settings, you're going to have one-on-ones with counselors. You might have weekly if you're an inpatient. You'll probably have monthly with outpatient unless there's a higher need. We have educational groups which teach people about the effects of drugs and alcohol. Cognitive behavioral groups help us to find the clinical thinking errors and critical thinking errors and help a person make decisions that are more informed with their values and more aligned with their values. You usually have self-help meetings that are required and random UAs. There are lots of options available. We talked about medically assisted treatment. So for opiates, we have Suboxone, Subutex, Vivitrol, Methadone, Naltrexone, and Naloxone. For alcohol, we have Torpamate, Antabuse, and Naltrexone, which is the Sinclair method, and Acamprosate. So the dosage might be here differently. Naltrexone is an opiate blocker. Okay. Naloxone is our Narcan, so that will bring somebody out of the brinks of death or overdose. Naltrexone is an opiate blocker, and the Sinclair method involves moderated drinking while taking naltrexone. So the person, if they want to drink, but maybe they have a problem with binge drinking, or this is really good for the person that can't stop at 1 and 1 turns into 5. But they don't want to give up drinking completely, they would take a pill every day, about an hour before they drank, and then they would journal their feelings and their experiences physiologically, psychologically, physically, etc. And then within 3 to 4 months, they notice a big change, and it has a 76 to 78% success rate. However, this would really disrupt current treatment. And I'm not aware of any treatment centers that do this. For alcohol, it's all abstinent-based. Naturopaths prescribe this. It's very inexpensive. It's about $40 to $50 a month. Insurance might cover it. Okay. And there's a documentary that I recommend called One Little Pill about this. It's been used by an American doctor in Finland for over 17 or 18 years with great success, and it is evidence-based. So we talked before about antabuse, which is aversion therapy. It would make a person very, very violently ill. And then these medications would help with cravings. Methadone is one of the oldest harm reduction medications that we have out there. It's a substitution. Vivitrol is an injection that lasts 28 days. It's like your flu shot. It's an intramuscular injection, usually in the bum. The downside here, though, is going to block the effects of heroin, which is good, but a person could overdose themselves by shooting up and trying to get the effect, which they're not going to feel. And then we have Suboxone and Subutex, which can be in a sublingual film strip or a pill form and taken daily. Okay. Right. Okay. Drug alternatives to traditional treatment. So here we're getting into some of the alternatives here. Ibogaine is a hallucinogen, and it's been said to reset the brain. There's a specific course that's used for it. Usually it's over a 3-day period of time, and the person has to, usually it involves medication. It might involve a shaman, and it's a specific dosage with meditation and mindfulness. Okay, and people go to other countries to get this done. We're seeing ketamine being used now, and there are several ketamine centers in Washington State, including one in University Place, not too far from us. And it helps with depression, PTSD, and chronic pain. And it's not something where you just, you go and you trip. That's not what happens. You're in a dimly lit room with a medical doctor and a therapist. You might have a heated blanket. You might have some soft music in the background, and they're going to take you through what you see. You're not just left alone. You can have an IV, or you can have the nasal spray, which is called S-ketamine, and you have to be there 2 hours afterwards to make sure that you have come back. Okay. They have been doing research with LSD and alcoholism, and they believe that LSD might reset the brain, because as we know, that alcoholism can lead to chronic depression and anhedonia, where the pleasure centers in the brain have been chronically depleted, some people believe that this might be a reset. And then we have MDMA, which is being used for PTSD in veterans. It's in development. And another part of that is using small amounts of microdosage of psilocybin mushrooms in teas, whereas a cup of tea a month could potentially take the place of taking antidepressants every day. And several states, as you know, have been working to make mushrooms legal. So if that happens, I'm wondering if possession charges and prison sentences are going to be commuted as well, because there are a lot of people in federal and state prison for trafficking and growing, cultivating, and distributing mushrooms. So we might be seeing something similar to what's happened with marijuana. Alternative program models. We have, I encourage you to look some of these up. There is a fantastic movie that I would love for you to watch on Amazon Prime called The Business of Recovery, which I think is very illuminating. And I encourage you to watch this if you have Prime or if you can get it in another way. These programs are mentioned, but you can look at any of these programs too. We have HAMS, which is Harm Reduction, Abstinence, and Moderation Strategies. It is a multimodal website with a lot of different tools on there. The Sinclair method, which we talked about. You're all familiar at this point with SMART recovery. We have moderation management. And then there are groups, and some of these have groups too. So the Sinclair method, you can do counseling, peer counseling with somebody, or counseling with a physician or not. They do recommend it because it, as we know, the more ways that we approach addiction, it's more successful than if it's a singular approach. So SMART recovery, we know that we have groups for this. There's individual things that you can do as well. Moderation management, they have online groups, but it's a lot about charting. Some of the groups that you might be familiar with are Rational Recovery, SOS, which is Save Ourselves. It's a secular recovery, not to be confused with SOS, Strength Over Speed, which is specific for gay men recovering from methamphetamine. Celebrate Recovery, which is a Christian fellowship based, and they look at a lot of different things, and they break you up into groups. Oh no, cat. Sorry, that was interrupted by my 20-pound cat over here being attacked by the parrot. It's never a dull moment at Dr. Housinger's house. Okay, so Celebrate Recovery. They have groups for porn addiction. So we haven't really talked too much about porn addiction. It's something that a lot of people do struggle with. Hypersexuality is in the DSM-5, but we know that sex addiction is not in the DSM-5 right now, and that was largely a political move. But Celebrate Recovery is quite interesting because if you go there, it's worship-based. It tends to be more positive, and they have family groups and kid groups, and they divide you up based off what you want to work on, and they do cover pornography recovery, which is great. 12-Step Yoga is from a woman named Nikki Myers, and she had done AA twice, and she was able to be sober for about a year each time. Her drugs of choice were alcohol and cocaine, but she noticed that she kept relapsing at the year mark, and she's like, okay, AA is helping me a lot, but what is the other missing link? And she found that it was yoga. So there are meetings around here where you can do a yoga class and go to a 12-step meeting. Okay. Refuge Recovery is based in Buddhist principles, and it looks at the Buddhist principles of suffering coming from attachment to negative thoughts, attachment to substances, attachment to people. And it's a different way to look at addiction. And then we have Women for Sobriety, which is gender-based, and there are meetings as well as a great online support community.